I'm going to get started. So welcome everyone. My name is Lauren Tobias. I'm going to be moderating today's sleep seminar. I have a few quick announcements before I introduce our speaker for this afternoon. In order to receive CME credit for attendance, please see the chat room for instructions. You can text the ID for this conference anytime until 3:15 p.m. And if you're not already registered with Yale CME, you will need to do that first. If you have any questions during the presentation, I encourage you to make use of the chat room throughout the hour. And we'll also have some time at the end for folks to unmute themselves and ask questions aloud. And then finally, please feel free to share the announcements for this weekly lecture series to anyone else who might be interested, or you can contact Debbie Lovejoy to be added to our email list. So with that, excuse me, it's my pleasure to introduce our speaker for this afternoon, Dr. Brian Koo. Dr. Koo received his medical degree from Tufts, completed a residency in neurology at Long Island Jewish Hospital, and his clinical sleep fellowship at Cleveland Clinic. He then went on to do a T32 research fellowship in sleep medicine, epidemiology, and neurobiology at Case Western, and stayed on there as faculty for 2 years prior to being recruited here to Yale. He's currently an associate professor in the Department of Neurology and has a co-appointment in the section of pulmonary critical care and sleep medicine here at Yale. And he's director of the sleep laboratory at the Veterans Affairs Connecticut Healthcare System. Dr. Koo is an internationally recognized expert in restless leg syndrome. He has authored over 75 publications on this topic. He speaks at national and international conferences. And fortunate for me as the fellowship program director and for our fellows here, he is an extremely dedicated educator on this topic. So he shares his expertise in RLS clinic with two of our sleep fellows each week in the RLS Center of Excellence that he's founded. And I think that our fellows are truly among the best trained in the country for managing RLS as a result. He has grant funding from both the Department of Defense and the RLS Foundation to study cerebrospinal fluid, melanocortins, and endorphin in RLS-related augmentation. And he has also served as a research mentor for numerous of our sleep fellows, but also several other trainees. And then finally, most recently and most relevant to today's talk, he is a co-author of the January 2025 AASM Clinical Practice Guidelines on the treatment of restless leg syndrome and periodic limb movement disorder. So with that, Brian, Dr. Koo, please give us your expertise. I see that the talk title for today is A History of Dopamine and Restless Leg Syndrome. I'll turn it over to you.
Thank you so much, Lauren. It's really my pleasure to talk to this audience about restless leg syndrome. Anytime I could get someone to listen to me about the treatment of restless legs, I'm happy. So thank you so much. I just want to just verify that you could see my screen because a little green outline is not there anymore.
It looks good. Perfect.
Perfect. Thank you so much. Okay. So this is the disclosure slide. None of this will, I don't have any financial relationships that are associated with this talk. You could text this number 47132 to the Yale CME text line.
Brian,
Yes.
the slides aren't forwarding.
Oh, I'm sorry. You're right. Okay. Thank you very much. You're reminding me to click it. Okay. All right. So this is a CME disclosure. I don't have any financial disclosures, and 47132 is the number to text the Yale CME text line. So the outline of the talk, I didn't in the title of my talk, I didn't mention ASM guidelines, but I'm going to be spending significant time going over those. But I think to set those guidelines up, I want to take you through a little bit of history of dopamine, its research, its implications in treatment, because it is somewhat confusing and actually it's quite interesting. So many of you know, and many of you were around, maybe not in 1961, but in the early 80s, when the first reports of treating restless legs with levodopa were introduced. These were in the early 80s, but even in the early 60s, it was known that dopamine blocking agents like antipsychotics could also bring about restless legs. And, these early kind of observations led many clinicians and clinician scientists to kind of think that dopamine had a large role in the pathophysiology of restless legs. And so it led to different scientific endeavors, but also there were increasing reports of the use of these medications. L-Dopa is levodopa for the treatment of restless legs, but also for dopamine agonists for the treatment of restless legs, which we're going to get into a little bit more. So here is another kind of early publication, and it's interesting because you would think that if levodopa or a dopamine agonist is successful in treating restless legs, well then there must be reduced dopaminergic activity in individuals with restless legs. And this was really kind of the prevailing thought for the better part of a century, and probably is thought by many even to this day as being true, even though it has shown not to be, which I will kind of go into in a little bit. Okay, so even early on in the mid 80s, when people, this is a group from, I believe from McGill, were looking at dopamine and dopamine metabolites, homovinylic acid and CSF, there was a hint of an increase in this in people with restless legs. But it's still confusing because why would that be? Why would dopamine help restless legs if it were indeed not reduced, but rather increased in these patients? I'm going to give people PTSD by pulling this slide up, but this is just to remind you that dopamine comes from the decarboxylating L-Dopa, which comes from tyrosine, and then you get dopamine. And there are a few dopamine metabolic products like homovinylic acid and 3-O-methyl-dopa that can be measured to assess dopaminergic activity in a person with restless legs. So this is another CSF study that was done by Chris Early, and he focused on homovinylic acid and 3-OMD, these dopamine metabolites, and found that in the CSF of people with restless legs, that these metabolites were elevated. So you could see that for 3-OMD, it was about twofold at night and interestingly threefold during the day. So again, kind of a hint that there was not a deficiency of dopamine, but possibly an excess dopamine. There was a similar story when people looked at the brain. This is Jim O'Connor from Penn State University collaborating with the late Richard Allen and Chris Early, and they looked at brains of people that were kind enough to donate their brains that had restless legs. And what they did was they measured tyrosine hydroxylase, dopamine itself, and also dopamine receptors. And they found that there was a slight increase in dopamine, but more impressively, there was a significant increase in tyrosine hydroxylase. And remember, this is the rate-limiting enzyme which causes the hydroxylation of tyrosine to L-Dopa and then to dopamine. So again, some evidence that there actually is an increase in dopamine in the brains of patients with restless legs. I'm not going to go over the technical aspects of this study, but it's a neuroimaging study, which again shows that there was increased D2 receptor binding potential. Decreased binding potential means that there is increase in dopamine. Okay, so the summary of the last few slides are just that in numerous research studies utilizing the measurement of metabolites in CSF, measuring different enzymes or proteins and neuropathological specimens, and also binding potential in neuroimaging, they all point to the likelihood that dopamine actually is in excess in restless legs. Okay, I'm going to shift more toward clinical history of treating restless legs. So I showed you this slide. This was the first slide. So this is the early reports of treating restless legs with levodopa in the early 80s. And so from the early 80s till about through the 1990s and kind of in the early 2000s, a lot happened. So yes, indeed, there were people that were using Cinemet for the treatment of restless legs. And then later, when the dopamine agonists began emerge for the treatment of Parkinson's disease, clinicians at the time who were treating restless legs were largely movement disorder neurologists. They began using dopamine agonists to treat restless legs and found that actually they were very, very effective in treating restless legs. And so over the course of years, let's see, sorry. Oh yeah. Okay, you're seeing, all right, that is changing. I'm getting confused because I'm looking at actually, doesn't matter the details. But over the course of years, this led to a series of, when I say series, I mean dozens of randomized control trials looking at the efficacy of different dopamine agonists for the treatment of restless legs. And almost invariably, these clinical trials showed significant efficacy of these agents. And because of that, this led to the FDA approval of ropinirole, Mirapex, or pramipexole, and then later rotigotine for the treatment of restless legs. So this is in the early 2000s. So you can see that there are many of these clinical trials. And so, as you can imagine, I hope you can hear this. You might remember seeing these advertisements.
My doctor said it's restless legs or RLS. The only RLS medication approved by the FDA. You count on your legs to get you where you want to go. When you suffer from restless leg syndrome, your legs don't want to stop. Even when you do, annoying sensations can keep up at night when all you want to do is get some rest. Fortunately, we can be on home. Mirapex is a prescription medicine that helps relieve the frequency and severity of many RLS symptoms, like those irritating sensations and the uncontrollable urge to move.
Whoops. Now, were you able to hear those advertisements?
A little bit. It was a little bit difficult, but we got that,
Okay.
I think.
Okay. Well, I mean, some of you may remember those advertisements. I actually do remember those advertisements. I was in my sleep fellowship in 2005, and I think that was kind of the peak of kind of the pharmaceutical advertisement. Turns out that they were extremely effective, the advertisements. And so, in preparation, I gave a talk that had some of a similar kind of flavor of the history of dopamine a few years ago, and I sent Christopher Early an email because I was interested in what happened. And so here is his kind of account through a personal email. So I'll just read it. Meaningful use of Cinemet did not start until 1988 to 89, but only a very small number of neurologists who had interest in RLS, Wayne Henning, Art Walters, were using opioids on a regular basis. When I started in 1991, Richard Allen was already an advocate of Cinemet and somewhat negative on opioids. At that time, Art and Wayne remained advocates of opioids. They published their results on augmentation in 1996, but it took over 2 years for most RLS experts even to believe their results. And then with the publication of Pergolide, the doping agonists became more popular. At that point, Wayne and Art shifted their opinion of the opioids and became strong believers in dopamine agonists. Once Mirapex was approved, most of the RLS experts who were also movement disorder experts started using Mirapex. And then Chris goes on to say it was the FDA approval of Requip for RLS, the accompanying advanced advertisements and doctor education that skyrocketed Requip into general use and thus a subsequent outbreak of severe augmentation among most RLS patients. By that time, I had already grown very negative about the unrestricted use of dopamine agonists and correctly predicted that about 2 years after the FDA approval, my clinic would turn into a dopamine agonist drug detox clinic, which it remains today. And so I can't recall, but this communication with Chris might have been 7 years ago. And I believe that for many of us who see a lot of augmentation, we've had kind of similar thought for the past perhaps 12 to 12, 12 to 15 years or so. And certainly the fellows have a lot of experience with augmentation, and they could say that largely my clinic is a dopamine agonist detox clinic today. That is true. Okay, so we'll talk about the treatment of RLS with dopaminergic medications. So here's one clinical trial. It's a 12-week double-blind randomized placebo-controlled trial. In just about all these trials, the main outcome is a reduction in the International RLS Severity Scale. So this is a scale that consists of 10 questions that outline things like the severity of sleep disturbance, the severity of the urge to move, the severity of mood symptoms, the severity or the degree by which you get relief with movement, and they're scored on a 0 to 4 scale, each of the questions. So the minimum is 0, the maximum is 40. In general, 10 to 20 is thought of as moderate RLS, 20 to 30 severe restless legs, and 30 to 40 very severe. Restless legs clinical trials, you always get a placebo effect, as you can imagine. It's a subjective scale. If you give a placebo, let's see. So the placebo is open circle, and you're going to see the symptoms start at 25, and they're going to, by week 8, they've already reduced by almost 10 points, so 9 points. But the dopamine agonist works better. So it goes from about 25 or 24 to about 10. So that's a pretty significant decrease in comparison to placebo. And you can see that when you compare the placebo decrease to the ropinirole decrease, there is certainly a significant decrease. And this comes to as no surprise to anyone who has used a dopamine agonist to treat restless legs. Patients are ecstatic. It's a magic pill. The restless legs is gone. They're sleeping well, and it's as if you've magically taken away the restless legs. I will note, so the other thing to note here is it's a 12-week trial. So 12 weeks is 3 months. And so many of the clinical trials were insufficient in duration to really properly assess augmentation. We'll define augmentation, and we'll talk about that. So efficacy and safety of, so here is just another trial of pramipexole, which is showing you, again, a large placebo effect, which is about 9, which is the same as the previous one. With doses of pramipexole of 0.25, you get a very large reduction, 13, and a little bit more with 0.75 milligrams of pramipexole. I should have put how long this was, but I didn't. Okay. Like I said, 3 months is not really long enough to properly assess augmentation. So the question is, what is augmentation? So augmentation was first described by Richard Allen and Chris Early in 1996. And if you can remember the personal email, Chris was saying that it took 2 years for even the experts to really believe that this was a thing. And I could remember myself in sleep fellowship. So I was a fellow at Cleveland Clinic in 2005. Cleveland Clinic is a program that is where the sleep program is housed in neurology, and it was Mirapex or more commonly ropinirole. And I remember thinking, I don't know what they're talking about with augmentation, because this medicine is fantastic. Um, but anyway, so what augmentation is a paradoxical worsening of restless leg symptoms in the setting of being on a dopaminergic agent. That could be either levodopa or a dopamine agonist. And the worsening occurs either by the restless leg symptoms occurring earlier in the day, the intensity of the symptoms worsen, there's a shorter time, there's a shorter onset time to get symptoms when one is not moving, and there can also be spread to previously uninvolved body parts. And so in their initial description of augmentation, out of 30 patients who were taking Cinemet, they reported about 80% developed augmentation. So just a very, very large number. And so, like it was mentioned, it took a few years for people to believe this, but people did finally come around, and they had a couple of workshops here at the NIH, here at Max Planck in Germany, kind of just refining the definition of augmentation. But these definitions are largely what we talked about, of the worsening, the timing, the spread to body parts, etc. And so, over time, people began to assess this more, and even some of these clinical trials tried to assess it. And you could see here, here's levodopa. Oh, I'm sorry. Jeez, I keep on. I'm sorry. I am looking at my. Okay, I'm sorry. I'm looking at my other screen, so I apologize. All right. So here are different studies that have looked at augmentation rates, um, and I think that these were probably done at different times when there was different acceptance of augmentation, because here you have a study looking at pramipexole. It is an 8-month study, and there's 0% augmentation, which is pretty hard to believe. These are probably more believable at 73%, but there's a variable rate of augmentation. But I will tell you that actually there probably is not really a single great publication or study which shows what the true rate of augmentation is. Here's a study published in the New England Journal of Medicine that looked at pregabalin versus pramipexole. And this I think they made a good effort to assess what the rate of augmentation is. This is a 52-week study, so this is 52 weeks in a year, so this is a year long. And you could see that pramipexole at 0.25, there was augmentation of 6%, and at 0.5 milligrams, that was 9%. And so you could see that there is some evidence that there is dose dependency of augmentation. And remember, a 52-week clinical trial is extremely expensive, and 52 weeks is a year. But many of these patients now have been on these medications for 15 or even 20 years. So there's a big difference between 15 and 1, the last time I checked. Okay, this is a study of it's an observational study of the Johns Hopkins kind of population. And what they did here is they looked at all their patients that were treated on various medicines. So if you just look at these graphs here, the bottom one is the rate of discontinuation from augmentation. And so you could see that the blue is pramipexole, a dopamine agonist, pergolide. The pink is another dopamine agonist that is currently not on the market, but is very effective to treat restless legs. And then the maroon is methadone. So you could see that there was no augmentation from methadone for both pergolide and pramipexole, if you take the kind of the difference of the two or the average of the two, there was like about like a 5 or 6% rate of discontinuation per year. And this is 10 years, you know. Let's see when this was. So this was 2011. And so, you know, if you remember in Chris's email, he said he started in 2001. Wow, that is 10 years. Okay. So 6% discontinuation per year. So this is probably more consistent with kind of the real world occurrence of augmentation. I'm just going to take a moment to talk about dopaminergic pathways. So for us neurologists, we like to think about these pathways, and it's interesting because there are kind of four main dopaminergic pathways in the brain. Here you could see, oh, sorry, I should be looking over here. Sorry. The pink or mesolimbic system, amygdala. You have the mesocortical system, which has which starts in the reticular activating system and projects to the cortex to produce arousal. This is why we're still awake, hopefully, and you're able to listen to the talk. The nigrostriatal system is in the substantia nigra. This is what gets disease in Parkinson's disease. You have deficiency of dopamine, and then the tuberoinfundibular system, which is related to the release of hormones. And so I mentioned this as a little bit of self-gratuity to talk to you just very briefly about my research. So in this hormonal system, you have dopamine that really causes a suppression of the release of various hormones. And mostly the one that you remember from medical school, I wish I could just ask people what they remember, which hormone was it, but I know people are muted, but it's prolactin. So prolactin is decreased by dopamine. So what am I doing here? Okay. All right. So let me see what my research is looking at. This is really, this is really self-gratuity. This is really kind of not related to the main part of the talk. So I'm sorry if you're confused. But anyway, my research relates to the melanocortin system and the possibility that the increase in melanocortins underlie restless legs. And so the melanocortin system, here's the main melanocortin hormone, pro-opiomelanocortin, gets broken down into the different melanocyte stimulating hormones and beta endorphin. These melanocyte stimulating hormones, if you inject it into animals, causes locomotion, insomnia, and periodic limb movements, basically recapitulating restless legs. And you could reverse that if you just inject beta endorphin. And so, and that's what this is showing. So it causes locomotion, it causes hyperalgesia, and it has kind of a circadian circadian rhythmicity to it that mirrors kind of the nighttime symptoms of restless legs. And so here, alpha MSH and beta endorphin are kind of, even though they come from the same prohormone, they're actually antagonistic to each other. Okay, I'm not gonna go to that because that. But anyway, so the reason why I think that dopamine suppresses restless legs is because it actually will inhibit the secretion of this alpha MSH. So I believe that this is, again, this is a self-gratuitous aside. So anyway, so that I'm going to get back to. All right. All right. So now we're going to get kind of into what I think everybody is interested in. So the recent 2024 American Academy of Sleep Medicine RLS treatment guidelines. Okay. So these restless legs guidelines have not been revised since 2012, which is quite a long time. And so here are the 2012 guidelines. And so you could see that the 2012 guidelines, there were two kind of standard recommendations. And the standard recommendations were for pramipexole and ropinirole. Okay, so this was based upon high efficacy, high level of evidence. And then guidelines were also, guidelines for the use of these medicines to treat restless legs: levodopa, opioids, gabapentin, enacarbil. And then this is a guideline not to use carbergoline because it causes heart valvular problems. So interestingly, we could look at some of this, and in 2012, remember that augmentation was introduced in 1996, and then maybe not well accepted until kind of the early 2000s. Still had about 10 years until this was published. So the authors did note augmentation. Let's see. Augmentation occurred in 1/3 of the patients. Let me see if sorry. I'm sorry. Oh no, I don't know how I could go back. Oh geez, I'm able to go back in my screen. Let's do this. I'm going to do this for a second. Okay. All right, so it's probably harder for you to see, but the average annual rate of augmentation lead to discontinued pramipexole. So they actually looked at that study that we just reviewed was 7% per year for pramipexole. So they did, they certainly did assess this augmentation. Now, and I'm sorry, I don't know how to go back on the full, so I'm going to again move this over to my other screen. So this is the current guideline, the 2024 guideline. And so, there's a little bit of a difference even in the methodology of the guidelines. And one big difference is that we use this grade criteria. And grade criteria stands for the grading of recommendations, assessments, development, and evaluation. And so the grade methodology takes into account kind of the certainty of the evidence, the balance of the benefits and harms, patient values, and also resource considerations. All right, so now I can go back to the full screen. I apologize for that. Now, in the grade criteria, different from what we used in 2012, you're going to provide strong recommendation. You could essentially give one of 5 recommendations: a strong recommendation for, a conditional recommendation for, a conditional recommendation against, a strong recommendation against, or you could give kind of no recommendation. And so this is busy, but I'll help you look through this. So we gave 4 strong recommendations for. These were for gabapentin enacarbil, pregabalin, and IV ferrocarboxymaltose. We gave about 6 conditional recommendations for. These were intravenous iron dextran, IV ferumoxytol, oral ferrosulfate, dipyridamole, oxycodone ER, and other opioids, and perineal nerve stimulation. Now, what many people are interested in hearing about are these conditional recommendations against these 4 dopaminergic agents. So levodopa and 3 dopamine agonists: pramipexole, transdermal rotigotine, ropinirole. And then we also give conditional recommendations against bupropion, carbamazepine, clonazepam, valerian, valproic, and strong against for cabergoline. So we're going to go over and try to explain the thinking behind these things. Okay, so we just went over this. And so I'm going to talk about kind of different medication classes and help you. Hopefully this will help you kind of understand the new recommendations. So the alpha-2 delta ligands, otherwise known as the gabapentinoids, the 3 of them all receive strong recommendations for. I think that most would agree that these are and should be considered first-line agents. There was a lot of evidence for gabapentin and acarbol. There were 8 randomized controlled trials, 3 observational. There were fewer randomized controlled trials for gabapentin, only 2, and 3 for pregabalin. The reason, there is certainly less evidence for gabapentin and pregabalin than for gabapentin and acarbol, but we decided to elevate the recommendation for gabapentin and pregabalin because of our overwhelming kind of clinical experience with these medications. Also, in the United States, gabapentin and acarbol is difficult to get by insurance. It's often not covered, and it can be quite expensive. And so, um, so if it's not covered, it may come out to be something between, I'm guessing here, but $500 and $1,500 per month, which is certainly not cheap, as opposed to gabapentin, which is just, pennies per pill. So I think, that these should be considered first line. One gets in the guidelines we do acknowledge that there are certainly some dose dependent side effects. Some people just feel cognitively fogged on these medications. So sometimes that will prevent you as a provider from reaching the dose that you need to treat the patient's restless leg symptoms adequately. But certainly a good option to have. Iron, I think it's time for our field to really kind of re-examine how we're treating restless legs patients. For the past 20 or 25 years, we've really kind of relied on dopamine agonists, and I and many other experts were also kind of guilty of just relying on them, and it kind of promotes kind of just treating by habit and not considering other factors. And so now that these dopamine agonists are no longer recommended as first line, I think we really have to think about how we're assessing and treating restless legs. And iron is critical in the assessment and treatment of restless legs. And specifically, intravenous iron is critical. So the one iron formulation that I got a strong recommendation for was ferric carboxymaltose. And this was largely because it had 5 randomized clinical trials, because this is one of the only iron formulations that is not generic. And but the data for efficacy is strong. Other iron formulations didn't really have randomized clinical trial data, or only one study. And these were low molecular weight iron dextran, ferromoxetol. Okay, so I will say, ferric carboxymaltose, many infusion centers do not have it available, so I personally have not ever used it. The formulation of choice, at least my formulation of choice, is low molecular weight iron dextran. Some of the advantages of low molecular iron dextran is that you can give it in one dose of 1,000 milligrams. But I will say I know that and when I will also acknowledge that when I first began ordering iron infusions, I also had some hesitation because you don't know where the patient is going. As a neurologist, I'm not a headache doctor or MS doctor. I don't really order infusions, so that is kind of a black box. The other thing that has happened, I think, with iron infusions, there is a false belief that they're very dangerous. And I think that this was perpetuated by, so high molecular weight and this is in the guidelines, we might as well just read it. An older formulation of iron dextran, high molecular weight, which is no longer available in the United States, was associated with adverse effects, including risk of anaphylaxis. And because of this, unfortunately, they have the same name of iron dextran. The one that we use and that is available is low molecular weight. And I don't believe that there are any reports of anaphylaxis with low molecular weight iron dextran. So, so rest assured that infusions of iron are safe. Infusion centers, patients are always monitored. There's nursing there. Often with iron dextran, people are given test dose anyway. All right. The other one, ferumoxytol, is also a possibility. The one I would say we didn't conditionally recommend against, but iron sucrose. There's a clinical trial that showed iron sucrose. The data were less strong, and many of us believe that it's the sugar component of the iron formulation that may make it less effective. Sugar in general, even eaten, makes restless legs worse. Oral ferrous sulfate is also an option, giving it 325 milligrams once a day is an option. We're going to talk more about kind of the ferritin targets and when I get to the good practice statement, because I think that is important to get. Oh, here it is. Okay, so good practice statement. Okay. And so maybe I should have talked about this first, because this is really critical in the treatment of restless legs, there are a whole bunch of things that can make restless legs worse. These are either medications that are prescribed, medications that are taken over the counter, things that a patient is eating or drinking or doing. And so it's really important to inventory all of these things before even considering whether or not a medication is warranted. And this includes assessing iron. So every patient that has restless legs should have their serum iron checked. And serum iron is best checked in the morning, fasting. And if they're taking iron supplement, you should ask them to stop it for 5 days and then get their blood drawn. And they should also be told not to have anything iron rich in the previous day. Okay. And so the goal is to have a transferrin saturation of greater than 20 and a ferritin of greater than 100. Which is very different from what the reference values will say, because the reference values often say if the ferritin is greater than something like 8, that it's normal. But when we see a ferritin less than 25, this is like, wow, this is quite low. So when a ferritin is low, you can use intravenous iron or oral iron when the ferritin is below 75 nanograms per milliliter. And the reason for this is because when it's a little bit higher, when the ferritin is between 75 and 100, oral iron is just not very well absorbed. And so intravenous iron is preferred. The other thing to note is that if you have a patient that's just got very severe restless legs, intravenous iron is just going to help much more quickly. You could give them an infusion. If they have a ferritin of less than 50, and you give them an infusion, there's a high likelihood that they're going to benefit immediately and for several weeks. Whereas if you prescribe ferrous sulfate orally, it will work, but may take a few weeks to actually help them. So just keep that in mind. So everyone should get their serum ferritin checked. Then you should ask people if they're drinking alcohol. That's very typically something that worsens restless legs. If they're taking anything antihistaminergic, dopamine blocking, serotonergic, I say, just because depression is so comorbid with restless legs that if they're on an SSRI, I often will just leave it alone. The medicines which I will stop are the serotonergic medications that also have antihistaminergic properties like mirtazapine, doxepin, or a tricyclic antidepressant. The other very critical thing is sleep apnea. Sleep apnea, when it's comorbid with restless legs, uh, just by treating the sleep apnea, you can often avoid using a medication. But when you're dealing with someone with severe restless legs and they have sleep apnea and it's not treated, it's much more difficult to control. So I'm always talking to patients about that we have to treat your sleep apnea in the setting of restless legs. Often they're very resistant, but you just have to stand your ground. Okay. So opioids. So this was also a tricky recommendation because there's only one randomized clinical trial of an opioid, and this was a clinical trial out of Europe that studied oxycodone extended release naloxone. And actually, this formulation doesn't even exist in the United States. You could only get OxyContin, but without the naloxone. And there was significant benefit over placebo with oxycodone extended release naloxone. And what we decided to do is we decided to broaden the recommendation. Extended release oxycodone, notice that we didn't include the naloxone because it's not available in the United States. And we decided to include the words and other opioids. So this was deliberate based upon our overwhelming experience with the use of opioids in the treatment of restless legs. It could be particularly helpful in helping to get somebody off of a dopamine agonist in the setting of augmentation. We'll talk about that in a bit. The ones that we often use are going to be methadone, and a somewhat newer medication that we're beginning to use more of is buprenorphine. We didn't there was not sufficient evidence to specifically make a recommendation on those specific opioid formulations, but by including these words, other opioids, and also referring people to other kind of guidelines from other RLS organizations like the Restless Legs Foundation or the International RLS Study Group, guidance from those.
Brian, sorry to interrupt. I think we just lost your screen. The
Oh,
screen share.
wow.
Not sure what happens.
Okay, so let
Yeah,
me.
but not your screen.
Can you see it now?
We see the whole desktop.
You see, like,
We see your Xywave script in the top. Yeah.
oh my gosh. I'm sorry, I have like 3 screens. How about now? That's better, right?
Perfect.
Okay, I'm sorry. Um, okay, yeah, so we decided to include these 3 words and other opioids just because of the great need to use opioids, particularly in patients with augmentation. So I do want to leave time for other questions, and I obviously need to talk about this. So the conditional recommendation against the use of levodopa and dopamine agonists. I mean, you could see here that pramipexole had 17 randomized control trials. Rotigotine had 8, ropinirole had 13. So there was a massive amount of evidence showing efficacy, but this was in the short term, right? And so, um, um, so certainly there's efficacy in the short term, but the task force was comprised of many of us that work closely with the Restless Legs Foundation. Through the Restless Legs Foundation, patients can reach out, and when patients are reaching out, you know that they have bad symptoms, right? And I would say more often than not, when they reach out, they're having augmentation. So they're desperate, they're looking for somebody that can help them. And and surprisingly, there are not that many people that can do it, sadly, that can help them. And so, at Yale, we have a Restless Legs Foundation recognized quality care center, which is the Yale Center for Restless Legs. and I get referred, augmentation patients a few a month, you know, and so my clinic is certainly not is different than the average sleep clinic. So the average severity of restless legs in my patients is going to be a lot higher than what is in the general population. However, these are people that are out there. And so, like was mentioned in Chris's email, um, there's probably, you know, a skyrocketing of patients with augmentation. And so combining kind of our knowledge with these clinical trials, knowing that the clinical trials were insufficient in duration to really properly assess augmentation risk. And from what we were seeing, um, this is why we made a conditional recommendation against. Now, it should be noted that the conditional recommendation against is not a strong recommendation, it's conditional. And so what we would talk about when we met in the task force was that these guidelines are for everybody. They are for primary care physicians, family physicians, um, that that don't have necessarily that much experience with restless legs. And um, so certainly, they should not be reaching for a dopaminergic agent as first line, right? Um, just because the medicines are fraught with so many problems. Let's see, we could talk very quickly. Impulse control disorder, very, uh, can be very disabling, often dose dependent, and people can lose thousands of dollars. We just saw a patient last week with the fellows who bought a Porsche 911. Um, um, Unfortunately, didn't drive it to the clinic, but he did in fact buy a Porsche. Um, Other symptoms of daytime sleepiness with sudden sleep attacks, postural lightheadedness. So the medications have serious side effects, and the most serious being the impulse control and augmentation. And so, we thought that we ought to give the guidance to people, particularly those who don't have that much experience in treating restless legs, um, that they ought to think twice about using these medications. Because while they're very effective in the short term, augmentation is going to occur. Like I said, RLS is chronic, and people will need treatment for often the rest of their lives. Which in many cases, if people get started when they're 40, when they're 80, that's 40 years later. Um, Now, conditional recommendation against also means that you can use these treatments. Um, Let me see if I go into, all right, I'm sorry, I should have made a slide with the recommended maximum doses of these medications, because you can use these medications, but if you do use these medications, you should monitor patients for augmentation. The other thing that you should monitor is yourself, because you should not increase the doses beyond the recommended maximums. And the recommended maximums for pramipexole are between 0.75 and 1 milligram. I probably wouldn't go past 0.75 milligrams. For ropinirole is 4 milligrams. For retigotine is 2 or 3 milligrams. Levodopa, I'm not sure, but I just wouldn't use levodopa. And so if you do decide to use one of these medications, certainly would not go past any of those doses. So the other thing to tell you is that a lot of you probably have patients on these medications. Certainly you should be asking them about excessive shopping and excessive gambling. If they have those, then you definitely have to decrease or even take them off the medication. Assess them for augmentation, and if they have that, you should decrease or take them off of it. But if they don't have either of those and they're doing well, they can be continued, but they just have to be monitored for augmentation, impulse control disorder, and and the doses should not exceed. Okay, so we're gonna probably didn't go fast enough. Treating augmentation.
Brian, you've got a bunch of questions in the chat as well. So I'll leave it
Okay.
to you how you want to spend the remaining 4 minutes.
Yeah,
Wrap up.
I'm
Got
sorry,
some
I
great
should.
questions too.
Yeah, so treating augmentation, a lot of this is mirrored on the good practice statement in assessing exacerbating things, sleep apnea, iron, tapering, the dopamine agonist. Often when you start to taper, you're going to start at the same time. Another medication to treat restless legs, we'd like to start with an alpha-2 delta ligand like gabapentin at 300 milligrams. You could increase by 300 milligrams every week or so. This is just an example of somebody is on 4 milligrams of ropinirole that you decrease by 0.5 milligrams every week. Now, you have to warn them that this is difficult. Their restless legs is going to get worse. You also have to warn them about possibility of depression, because if you withdraw the patient too fast, they can get dopamine agonist withdrawal syndrome and become depressed and despondent. So you have to tell them about that, warn them about that. And then clinically, the other very important thing is to just be available for the patient, because you have to keep the lines of communication open so that they don't feel like they have nobody that they could check in with. And this doesn't have to be time consuming, because I tell my patients that, you could message me through my chart. That's the way to get to me, because, I, I don't want to be talking to someone in the middle of the night, but I'll be happy to answer your my chart message and advise you. Okay, so let's get to so I think in summary, the history of dopamine with restless legs has been very complicated, has been interesting. Um, uh, you know, there has basically been a sorry. So all the research points out to that there is likely a hyperdopaminergic state in restless legs. So it's not that surprising that a dopamine agonist would lead to worsening of restless legs. The other take-home point is RLS is treatable even when very severe. When they're medication naive, start with gabapentin or pregabalin. Do not start with a dopamine agonist. If using a dopamine agonist, warn them about impulse control augmentation. Do not exceed 0.75 for pramipexole or 4 milligrams of ropinirole. Then when treating augmentation, always encourage the patient that things will get better, but warn them that they will need to go through a very, very tough time over the next days to weeks. And again, be available to answer their messages.
Thank you so much for such a clinically informative talk, Brian. That's really helpful. We have several great questions. Maybe I'll take one that I personally would love to hear the answer to, because I wasn't even aware of this paper. So Joyce Lee Ionati, who's at University of Arizona, sorry. Hi, Joyce. She asked your thoughts on a paper that came out of the Mayo group in JCSM, looking at disparities in ferritin level testing. And apparently there's different methods of doing this. If you're familiar with this, she said apparently there are some methods where they overestimate true iron storage levels. And she's asking if you have any advice on conversion methods and or which assay should be used, I think, basically.
Yes, I have not seen that publication, but I have heard this issue. I myself do not have knowledge on how to deal with this. I would say that somebody that might be able to help you, Joyce, is Andy Burkowski. I think he may know, but yes, that is definitely a big problem.
All right, thank you. And then maybe I'll take another question. This is from our former fellow Vesna. Hi, Vesna at Brown. And she's asking about a recommendation that I believe is new in the 2025 compared with 2012 guidelines, which is the perineal nerve stimulator. And I know this is mentioned, I believe, with a conditional recommendation. And so what is your experience with it, was her question.
Yeah. So we've been very excited about this. The data are promising. The data, if I were to go by memory, shows compared to placebo that there was a significant benefit of it. And, it's always great to have something that is non-pharmacologic. So I have prescribed it to about 8 to 10 patients. I will say that only so far one has gotten it. The company has been really good at trying to help interface with insurance to get it paid for, but there has been variable success. So I don't really have any experience to talk about other than I prescribed it, and the patient who has it hasn't even come back yet to my clinic, so I'm not sure.
I'm assuming not on the National VA Prosthetics formulary yet.
No.
Your knowledge. Okay, great. And then maybe I'll take one more question, which is from someone I'm trying to find the question now, but so yes, the question is, I often have difficulty getting my patients to accept that they clearly have symptoms of augmentation. Do you have any advice, since this would be the first step to discontinuing what they've been on for several years? And I imagine you've had experience with this. I certainly have myself.
Yeah, I mean, you sometimes that does happen. I will say that perhaps it doesn't happen with me as often because I'm getting patients that are driving to me from different states. So usually those people have accepted it. So um um so it could be that these are patients that are mildly augmenting and that you're increasing the doses and maybe they're on, 0.5 of Mirapex and they're asking you, oh, my symptoms are worsening. Can you just increase it? So that circumstance, I don't run into that much, but probably many of you do. And I would just tell them about the evidence that or what they're likely to experience. Because if you go up to 0.75, they'll be okay for maybe a month. It's hard to predict. Maybe more than a month, but they will worsen, and then they're going to be at the same point, and they're going to be wanting to go up to 1 milligram, and that's going to be a repetitive, iterative process, and then the end result would be that they're on a very high dose. And what I would tell them is that if we go up, you're having augmentation, you're going to get worse. And if we nip this in the bud and do it right now and get you off of it, it's going to be easier because it's easier to get off of 0.5 milligrams than it is 1 or 2 milligrams of pramipexole.
Great. Thank you so much, Dr. Koo. Thank you, everyone, for being here. I just want to highlight next week's talk, which I think also will be fantastic. We have Dr. Kirat Gill, who is at Stanford, and she's going to be speaking about their hypoglossal nerve stimulation program there, including some of the more challenging cases that they've seen and how they do HNS titrations at their center. So please join us again for that next week, and have a wonderful week, everybody.